All right, I think we'll go ahead and get started. So welcome to the Fertility series. This will be Fertility 101. It's the first of a 3 series. And we'll go ahead and start with Dr. Abigail.
Hi guys. So am I correct that everybody here is nurse, correct? That's what I kind of gathered. No, not you. Okay. So I know most of you. So I'm from here. I'm from Omaha. I did my medical school and residency here, and then I did my fellowship up at the Mayo Clinic and came back here. It'll be 3 years on August 1st. So I'm going to talk today about kind of female infertility, how to make the diagnosis, kind of what goes into making the diagnosis, some basic kind of workup that we do, and then the next 2 in the series, the next one I'll talk about treatment, and then the third one, Amy and I will kind of tackle that one together, and we're going to talk about andrology, so kind of male factor infertility a little bit, and then an IVF, okay? So I don't have anything to disclose other than, you know, I have allergies, so if I sound nasally, it's, that's why. So this talk was actually originally, I pared it down, and it came from like learning objectives from actually a fellow lecture. So if you see these, you don't need to know everything of these. I've tailored it more towards like a nursing audience, but just suffice to say that obviously things are a lot more complicated than just in this talk. So we're going to talk about kind of 5 different things today. We're going to talk about just like overall female reproductive potential. We're going to talk about ovarian factors that contribute to infertility, tubal factors that contribute to infertility, uterine factors that contribute to infertility, and then I'll get into a little bit of other therapies and just kind of basic touch on kind of treatment, but the lion's share of that will be in the next lecture, okay? So it's always greatest to start with the definition, so like what is infertility? The American Society for Reproductive Medicine defines infertility as 1 year of unprotected intercourse with no conception. However, in 2012-2013, there was a new caveat that went on. So this has changed in 2012-2013. And so what they started to say is that infertility, though, can be diagnosed if a woman is over age 35 and they've been trying for 6 months and they're not pregnant at that time. That's when they start. So subfertility, which is kind of what the majority of our patients are decreased reproductive efficiency. And what I mean by that is, you know, they can get pregnant, but it just takes a lot of work and a lot of effort in order to get them there. Fecundability is the probability of 1 cycle resulting in pregnancy, and fecundity is the probability of 1 cycle resulting in a live birth. So I talk to every single one of my patients about fecundability. I think this is a really misunderstood topic because particularly for our patients that are trying so hard to conceive, everyone thinks that it's so easy for everybody else. But it's important to kind of remember even people with no fertility issues, just trying to get pregnant on their own, they get pregnant the first month. Their chances per month are only 20%. So that's the gold standard. That's the highest bar we can meet as humans is 20% per month. So I think you as nurses are on the front lines of answering those phone calls from worried patients and saying, you know, why can't I get pregnant? So I think if you can tuck that little statistic in the back of your mind and sort of say, hey, listen, guys, you know, I understand it's obviously very frustrating, but you're okay. Like it's not 100% every time. It's only 20% per month. So the average time required for conception, so this is where the year of infertility was sort of built off of. So if you've been trying for 3 months, the chance of conception is 57%, 6 months, 72%, 12 months, 85%, and then after 2 years, 93% get pregnant. So again, just a global picture of how inefficient we are as humans in getting pregnant. At a year of unprotected intercourse, only 85% of us are going to be pregnant. It takes 2 years to even get in the 90s, okay? So we're all kind of walking around miracles. I don't know how it always happens that way, but those of you that work in labor and delivery, you get to see that every day. So I usually lump causes infertility for females into causes of infertility into 4 different categories. So I generally tell my patients about 40% of the time it's female factor, and we'll talk about kind of all the different causes. About 40% of the time it's male factor, and the remaining 20% is divided half and half into unexplained, meaning I could run every single test under the sun and never find anything, and combined, meaning that usually I'm not going to find a cause until we do something as invasive as in vitro fertilization cycle, and I might be able to find something like there's a poor fertilization kind of at the time of IVF, there's poor embryo development, there's poor embryo quality. So those are all things those are the combined or unexplained that sometimes we find when we do IVF. So again, indications for evaluation. Greater than 12 months of unprotected intercourse without a successful conception. So what I have patients tell me all the time, which is kind of funny, but like it's actually not funny, is they'll say, well, I've been having unprotected intercourse for 6 years, but only actively trying for 1. No, doesn't count. Doesn't count. You've had unprotected intercourse then for essentially 6 years, and that is clear infertility. So if patients say, I've been having unprotected intercourse for 3 years, they're infertile. Like that, they meet the definition. So I think it's really important to sort of dispel that myth with patients that like you have to be actively trying. If you're having regular unprotected intercourse 1 to 2 times a week for a full year, you should be pregnant. And if you're not, then there's infertility at hand. Okay. I would say in patients who they've been trying for 6 months and they have these other things, like they're not getting periods, okay? They have a history of fibroids and they've had surgery. They've had a history of many sexually transmitted diseases. They have a history of endometriosis. Or their male partner has a history of like, I've had multiple inguinal hernia repairs. I've had testicular surgery. I torced a testicle when I was playing sports when I was a kid. I mean, all of those things warrant an investigation earlier. And I think the point that I think our office would like to make, particularly to generalists and everyone out there, is that just do the workup. Like it's not, we'll talk about what the workup is. It's always better to err on the side of finding a cause or at least doing the evaluation as opposed to just like letting them continue to try. Because that sort of wound festers if they've been trying for 1 or 2 years and then we piecemeal it. It's just important to just treat it like the disease that it is. Find a root cause, and if you can't find a cause, then send them to us. Ideally, of course, you're going to want to evaluate them at the same time. Kind of my montage is no patient leaves my clinic without having a semen analysis. I will not give medication unless I have determined that there's a male, that there's sperm. Females automatically share and carry the burden of not being able to have kids, and males need to participate in like the workup and the evaluation. It's and so I always tell patients, it might not be you. I mean, we all think, okay, and I'm an infertility survivor myself, so we're kind of like, it's me. But it's not always that case. 40% of the time it's the male factor. So don't just hand out Clomid, don't do things like that because you're negating half the story. Okay, so how do I evaluate ovulatory function? So how do you find out if people are ovulating? So let's first talk a little bit about ovaries, okay? So we all know that we have a finite reproductive lifespan. The literature would say that at age 35, we start to see a decline in the ability to get pregnant. And then that drops precipitously at age 37, 38, 39. And in addition to not having an easy time getting pregnant when you're older, up to 60% of conceptions miscarry in the first trimester, and 20 to 40% of all pregnancy losses go unrecognized. This was done on studies of natural populations. I'm sure you guys have heard probably the Hutterites. They're actually a Scandinavian population group that lives in northern Minnesota, and they do not believe in birth control. And so all of the studies on natural fertility decline have been done on this population where they never use birth control and looking at kind of their time to conception. Okay. As far as decreasing fertility of males, aging doesn't seem to affect the male population as significantly as the female population. So I usually tell my patients with advanced maternal age that I don't see a significant decline in their fertility until men reach the age about 50, and then we see it, okay? more on that next time. So follicular depletion, so as we age, we just lose follicles. So the most amount of eggs that you're ever going to have in your entire life, and everybody except for you as a female in this room, is actually in utero. So as a baby, that's the most amount of eggs that you're ever going to have. And in utero, babies start losing eggs. There's just atresia, and like we just start losing them, okay? Through kind of like from birth to about puberty, that decline isn't so severe. But then from puberty to menopause, again, it just kind of declines. And so the bottom line is, as we age, the rate of that decline goes faster and faster and faster. So as far as like when we age, what happens? So this is when we're talking about kind of the evaluation for, ovarian reserve. So the luteinizing hormone and follicle stimulating hormone are hormones that come from your brain, which actually communicate with your ovary and say, hey guys, make an egg. And what I will tell you is that the LH concentration, you can measure LH throughout a reproductive lifespan, it doesn't change, okay? It's the same. But there is a rise in FSH, so follicle stimulating hormone starts to rise. We start getting a little nervous about it when it's over 10 million international units per milliliter. But I will tell you that even in our clinic, we start to get a little bit worried if they're age 37, 38, and their FSH is already like 9.8, because we feel like that is demonstrating some ovarian aging. Inhibin B is another hormone that, patients get on the internet and they'll ask about it. It is not recommended to test. The assays are difficult to ascertain, so just sort of ignore that and say, no, FSH is the best test to do, again, as far as reproductive aging. And what you'll also see is as women age, their cycles become shorter. So all of the studies, everything with fertility is based on a 28-day menstrual cycle. But as you age, that menstrual cycle is going to get shorter and shorter and shorter. So you'll notice chronologically in women that, well, at age 34, yeah, my cycles are every 28 days. They're like clockwork. By the time they reach about 40, oh, yeah, well, I've noticed probably over the last 6 months to a year that my cycles are now 24 to 25 days. And that is because that FSH rises earlier and starts recruiting a follicle earlier, and so that is sort of the natural progression. Aging follicles are less sensitive to gonadotropins. We see that all the time. So what I mean by that is we can blast these women with medication to try to make them make more than one egg, and their ovaries just don't respond. So age is the single most important factor in IVF or ART, assisted reproductive technology success, regardless if calculated by cycle, oocyte retrieval, or per embryo transfer. It all depends on age. So, and this is really interesting because I left this in here for like Amy, look at how much better our success rates are compared to 2007. So that's great. So age less than 35, 12 years ago, the success rate with IVF was like 46%. Now we generally quote around 65% per transfer, and a live birth rate of around 45 to 50. So this is just, it's gotten a lot better. So in addition to decreased success with fertility, we have a genetics and reproductive aging, so decreased oocyte quality. And when that happens, we also get errors in when eggs and sperm combine. And when that happens, you get genetic abnormalities in the offspring. So that's where you have an increased risk of having babies affected by Down syndrome, trisomy 18, trisomy 13 in advanced maternal age. It seems to be the smaller chromosomes are more prone, i.e. trisomy 21. That's a very, very small little tiny chromosome. Most of the time we see trisomies. A lot of times we see polyploidies, and a lot of times we see monosomy X. So if any of you have a friend or colleague or someone in your family with Turner syndrome, most of those patients actually, they're very lucky to be alive. Most of those miscarry. So I generally quote the risk of aneuploidy, meaning abnormal chromosomes in women under the age of 35 is 10%. But by the age of 45, it's 100%. By the age of 43, they have a 50% chance of having aneuploidy. And that's why women, as they age, in addition to having trouble getting pregnant, they also miscarry, because these pregnancies have a tendency to attach, but it's sort of Mother Nature's way of saying, this is not going to result in a live birth. So ovarian reserve testing. I'm going to focus on follicle stimulating hormone, estradiol, anti-Müllerian hormone, and antral follicle count. I didn't know if Janice was going to be here today. I was going to talk about the Clomid challenge test, but I don't see her, so we're going to ignore that. Okay, how do I order FSH and estradiol? So this is when we have our patients, we say, hey, listen, call us with the first day of your period, and we're going to get you in. We're going to do some blood work on day 3. And like I said, we order follicle stimulating hormone, which again is the hormone that comes from the brain, which talks to the ovary. If it's greater than 10, the specificity is 80 to 100% for poor response to stimulation. And then we also worry if that estrogen level is greater than 60, because what can happen is if that estrogen level is high but the FSH is low, if you guys remember, there's that negative feedback. So as estrogen level rises, FSH goes down. And so the problem is if that's elevated, it can sort of mask or make it look like the FSH is normal, but it's not. Now, just because someone's estradiol is greater than 60 on day 3 doesn't always mean diminished ovarian reserve. Lots of women are like running around with just higher levels of circulating estrogens, most commonly in the PCOS population. So certainly I feel like that's not what I'm the most worried about. I'm more worried about the FSH. Some recommend a repeat once. I do not. And the reason why I don't is because you're only as good as your worst FSH, and I always combine it with another test, anti-Müllerian hormone. So anti-Müllerian hormone is a hormone that is secreted by the granulosa cells of the ovary. So around eggs, there's these little cells called granulosa cells. And it is the same throughout the menstrual cycle. So unlike FSH and estrogen, you can do this at any time. You can do this when they're on birth control pills. You can do this whenever you want. It doesn't change. And that is the benefit of anti-Müllerian hormone. In the general population, it's a predictor for poor ovarian stimulation, but it's not a predictor for pregnancy. So I get a lot of consults from the docs downstairs where they will incidentally find someone with a low anti-Müllerian hormone, and the patient will come upstairs terrified that they're never going to be able to get pregnant. And here's what I tell them. It is more useful in older women, meaning that if you randomly check an AMH on a 28-year-old and it's low, doesn't mean as much to me as if the AMH is low at age 38. And the reason why is because your age still wins. At 28, you should still be able to get pregnant because this is just a marker of the number of eggs you have, not the egg quality that you have, okay? And so what I use AMH for in my population is because they meet the definition for infertility and I need to know how to treat them. And it guides me for using AMH to figure out the dose of medication that I need to use in order to help them be successful with fertility treatment. And it also, combined with the FSH and estradiol, gets me a global picture of what's going on in the ovary. But I think the take home and what you can tell the doctors downstairs and what you can kind of tell patients that call is that it's not 100%. It is not the test. It is not a be all end all. Like, this is just it's a test as part of a global workup to figure out exactly how your ovaries are functioning. If you have a friend or family member that has a low AMH, that does not necessarily mean that they are not going to ever get pregnant. It's one test, and that's all it is. And the biggest thing that it predicts is how I can use medication and poor response to medication. So in somebody who, I have plenty of patients that have an AMH that's 0.4 and they've got 4 kids. But if I try to stimulate them to try to get them pregnant for a 5th kid, it's going to be harder for me to stimulate them and have success. And that is what AMH tells me as a fertility specialist. But for the global population, it's not as useful, okay? We also do something called an antral follicle count. So that also is done on cycle day 2 to 4. And what we're doing, this is just a picture of the ovary, we're basically counting the number of eggs on the ovary. And honestly, what I feel comfortable, what I like to know is like that is greater than like 10 to 15, okay? When I only see like 3 to 4 eggs on combined ovaries, again, that heralds to me that if I stimulate somebody or if I'm trying to get them pregnant, then I'm only going to get 3 to 4 eggs. That's all that's there. But the average normal reproductive age woman should have 10 to 15 eggs. Now, when we do like PCOS patients, they're going to have like greater than 25 eggs because they have 12 eggs per ovary, okay? And that sort of meets the criteria. But the bottom line is it's sort of, again, an overall global picture of like, what do the ovaries look like? How are they functioning, okay? So thyroid is associated with fertility. So in addition to ordering follicle stimulating hormone, estrogen, and anti-Mullerian hormone, I always order TSH, okay? TSH is the hormone that is secreted by the brain. We know that as TSH rises, that's what causes hypothyroidism or low thyroid. And as TSH declines, that's when we see hyperthyroid. Again, that's that negative feedback, reverse thinking, okay? And in our clinic, we always treat to a TSH of less than 2.5. And the reason why we do is because there have been multiple studies that have shown that in women, particularly in women who have positive thyroid antibodies, meaning that they've had an autoimmune condition that causes them to have thyroid, that low thyroid, they have an increased risk of miscarriage if their TSH is not treated to a less than 2.5, okay? There is some controversy out there, okay? So ASRM just came out with a new document, it was a couple of years ago, that basically said it's okay if your TSH is less than 4, and that there's this gray area of less than 2.5. But our standard clinic and the way that we do it at RHS is we always treat to a TSH of less than 2.5. And what I tell patients, if they call and they ask, is the following. 90% of women in the reproductive age group should have a TSH less than 2.5. So if your TSH is higher, then you're in the 10% of women that's not, like, it's not an average at all. And the only thyroid hormone that your baby gets until 20 weeks is from your thyroid. And so if you do not have enough thyroid hormone circulating in your system, we see brain development problems, we see increased risk of autism, increased risk of developmental delay. And so the bottom line is it's always better to have a little like whiff of Synthroid on board. Usually if their TSH is like 2.69, I always tell them, I'm not dooming you to a life of Synthroid. That's not, you're not diagnosing you with hypothyroidism. But what I am telling you is that while you're trying to get pregnant, I want you to have a little bit else on. I want you to have a little bit on board, okay? All right, so PCOS. This is one of my biggest pet peeves in the entire world. And like, it just drives me crazy. It is a diagnosis of exclusion. If someone comes to you and they're like, I have irregular menstrual cycles, the knee-jerk reaction from pretty much every provider is, well, they probably have PCOS. Maybe they do, but you have to find out if that's correct. Like, you have to do the workup. So what do I mean by the workup? If they're having irregular thyroid, or if they're having irregular periods, you have to do a TSH. You have to do a prolactin. Now, as far as looking at like other hormones, testosterone, free testosterone, we can go into an argument about that later, but the bottom line is you got to do a TSH, you got to do a prolactin, and I would suggest you get an ultrasound. Those are the 3 things that you need to do in order to do that. Now, how do I make the diagnosis of PCOS? So that hinges on what's called Rotterdam criteria, okay? Rotterdam criteria was developed by a study, and what they have determined is that because the spectrum of PCOS is so wide, you need to have 2 of 3 of the following criteria, okay? You have to have abnormal menstrual cycles, okay? You have to have signs of male hormone excess, meaning that there's acne, hirsutism, meaning hair growth in the male pattern, or polycystic ovaries on ultrasound. And that's where you get like the greater than 12 antral follicles per ovary, and sometimes people would say an AMH that's like greater than 6, okay? But you have to have 2 out of 3 of those things. So if someone comes into you and they have irregular menstrual cycles, but their ultrasound is completely normal, they don't have PCOS, okay? Unless they have, like, I have irregular menstrual cycles, but I'm covered in hair and I've got acne all over, then they have PCOS. But again, it's a diagnosis of exclusion, and you have to use the Rotterdam criteria or you can't make a diagnosis. And so the number of patients I have that come to me that just have this blanket diagnosis of PCOS and someone gave them letrozole or Clomid is in the thousands, and sometimes patients are given that inappropriate diagnosis and then given medicine for it that would never have helped, okay? And so that's why it's everyone's job as providers. You know, I tell my med students and residents, I was like, If someone came to you and they had palpitations, you wouldn't say to them, I'm just going to give you a beta blocker and we'll see if that helps. Like, you wouldn't be like, yeah, you know, it's probably fine. Like, don't worry about it. We're just going to give beta blocker. It's the same with PCOS and Clomid. Like, you don't just give somebody like Clomid without doing a workup. Like, do the evaluation so that you have an idea of why you're giving the medication and if it's going to work, okay? All right, how do I assess ovulation? So patient says, I'm having irregular cycles. Okay, well, how often are you having periods? Every 28 to 30 days. Okay, do you have symptoms when you get your period? And mostly it's like breast tenderness, moodiness, I'm gonna kill my husband every month. You know, I mean, like all of those things. And that really truly does, even though it's not every 28 days, that does indicate that there's an ovulation. Some people do, what they do is they, 7 days before expected period, you can do, or a day 21 progesterone. You can see whether or not, because progesterone should rise after they've ovulated. But here's the caveat about ordering a progesterone. If they have 35-day cycles and you have them come in on day 21, their progesterone might not be elevated because they haven't ovulated yet, or it's not appropriately timed. It truly has to be 7 days before the expected menstrual cycle. Again, it all depends on this, like, you know, perfect 28-day cycle, which we all know that's not the case. That's just not like life. Life doesn't happen that way. So the bottom line is, it's a good test if you're timing it appropriately. It's a bad test if you're not timing it appropriately. What we usually tell patients to do is to do ovulation predictor kits. And so what I tell patients that, you know, they're just coming to me, I can't figure out whether they're ovulating or not. I say, hey, you know, starting on cycle day number 10, I want you to use ovulation predictor kits. I want you to pee on that stick every morning, and when it comes positive, you know, you can give us a call and we usually do an evaluation. But if you don't have access to like what we do, you can just say, you know, start on cycle day 10 and start mapping when it comes positive. And if it's regularly positive, like every month on day 14, day 15, then they're ovulating, okay? There's a 7% false positive rate with these tests. So it's a good test. They're cheap. You can order them on Amazon. You can get them in like packs of like hundreds, okay? But the only proof of ovulation is pregnancy. So, you know, all of these tests, you know, you can do it clinically and evaluate their cycles. You can do like the day 21 or the 7 days before the expected menses progesterone, but truly that's the only kind of way that you can say, oh, you've definitively ovulated. What is no longer recommended is basal body temperature and endometrial biopsy. So a lot of people will be like, well, I'm doing these basal, I'm monitoring my temperature, and that's great, good for you. But the actual kind of, it is very, 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 very hard to get a true basal body temperature. It has to be like first thing in the morning. You can't have anything like in your mouth. You have to like not even like lift up your head. And so the bottom line is there's a ton of user error with that, and so I typically don't recommend it. I prefer science and like using data, and that includes like ovulation predictor kits. So who do I order these on? So truly, I feel like they need to be ordered on anybody with infertility. But if you're trying to do cost saving, then these are the people that really need ovarian reserve testing. If they're advanced maternal age, so greater than 35. If they've had a history of chemotherapy, radiation, or they've had ovarian surgery. If they're a smoker, okay? If they're having shorter cycles, remember what I said, like as you get older, those cycles shorten. If they have a family history of premature ovarian insufficiency or family history of early menopause, or if they had a history of they did IVF and like they got like 2 or 3 follicles. Every infertile patient needs a thyroid test. And then you can we can argue about PCOS. As long as you get a TSH and a prolactin and an ultrasound, then that is an efficient evaluation. So what can you do to tell patients as far as like lifestyle factors and how can they improve their fertility? So we tell every patient that they can have no treatment with us unless they've had 2 months of, unless they've been quit smoking for 2 months. And there is real data to support that. Smoking is terrible for the ovaries. It causes accelerated follicle depletion. People that smoke and have a long smoking history go into menopause earlier. They have irregular menstrual cycles. It also affects tubal function. The cilia that live in the tube don't function normally, and patients that are smokers have increased risk of ectopic pregnancy. So the bottom line is that's the one, a lot of them have no control over their fertility situation, but if they're a smoker, that's the one thing that they can control. Go ahead.
Like secondary smoke.
Yeah.
And how many couples do we have that you'll put them in the car and then their husband opens the door and they're like,
Yeah, it does.
why?
Yeah, it does. Unfortunately, I feel like, infertility patients are a very captive audience. They want to do whatever you tell them to do, which is really nice. My husband's an internist, and if he had that kind of experience with telling diabetics they need to lose weight, and man, he would just be like, this is the greatest thing ever. So I can tell a patient you need to stop smoking, and they might actually do it. But again, it's very female-centric, and the men don't always participate as much in the treatment as the females do. We try our darndest to get them to do everything, but it's hard. So, but yes, second-hand smoking, yes. Marijuana does inhibit gonadotropin secretion, so it actually causes kind of a hypothalamic dysfunction. Clearly, cocaine is bad. Don't do cocaine. Alcohol actually does decrease fecundability, which, it's interesting, but it really does. So I generally tell patients that, they shouldn't be binge drinking. And that's the general consensus. They can have, a glass of wine at night. That's like commonplace in Europe, and their fertility rates are the exact same as ours. So, but the bottom line is, okay, caffeine. Do I need to quit coffee? If I quit coffee, I would not function. So the answer is no, but you should limit it to what we recommend in pregnancy, less than 250 milligrams per day. And that amounts to either a cup of coffee or like a couple sodas. We tell all of our patients not to take any NSAIDs, so no ibuprofen, and it's because it disrupts the normal ovulatory process. So when a follicle is released from the ovaries, there's the prostaglandins are used to kind of rupture the ovary and release the follicle. And if you've taken an NSAID, it could have disrupted that prostaglandin secretion. So that's why we tell patients that. How often do I need to be having sex? Again, if I had $1 for every time, we've been having sex every day for the last year, and I'm like, oh, okay. I will tell you that, really, you need at least twice a week, okay? And 2 to 3 times a week doesn't really, statistically make a difference. It's just regular, unprotected intercourse is twice a week, okay? All right, tubal function. So we live in, the chlamydia capital of the world. So we see this a lot, but truly, Douglas County in the state of Nebraska is incredibly high on the CDC list for chlamydia. And so what I would say is in infertile women, 30 to 35% have tubal factor, but I would say in Omaha, Nebraska, that's higher. And things that increase your risk for tubal factor fertility, of course, is PID, okay? But other things do also increase it. I can't tell you the number of times I've diagnosed tubal factor infertility on a patient with Crohn's disease from inflammatory bowel disease. And something that is constantly missed by primary providers is this idea of an perforated appendix or appendicitis. What is appendicitis? It's pelvic infection, right? And if there's a pelvic infection and it's pretty near to the tube, that can certainly cause tubal factor infertility. So again, just things to kind of think about in the back of your mind when you're thinking about, this patient, why is this patient not getting pregnant? If they've had a history of an ectopic pregnancy, certainly that is the definition of tubal factor, right? They've had endometriosis or they've had tubal surgery. Risk of hydrosalpinx, meaning a dilated fallopian tube, increases with the number of pelvic inflammatory disease episodes. So 1 episode, you have a 10% risk of affected tube. 2 episodes, 30%. 3 episodes, 60%. I'm not going to get into the proximal distal. I don't feel like that's necessarily important at this time. But let's talk about how do I evaluate tubes, okay? So the gold standard is this hysterosalpingogram. So it's this dye test, okay? And what it tells me, it does not tell me tubal function. That's the unfortunate. No test is going to be able to say, hey, listen, your tubes are working great. The only thing I can tell by really any study is, are they patent? Do they open at the end? Okay? And I get some information about the uterus, but not a ton. It's not a very sensitive test to like if you're worried about a uterine polyp or if you're worried about a fibroid, if you're worried about something like that, okay? So this is what a normal HSG looks like. So you see kind of the triangular uterine cavity, you see fill on the right, you see fill on the left, and you see spill. This is what a hydrosalpinx looks like. So you see the cavity looks normal, and then you see this big old dilated tube, and there's no fill at the end. There's no spill at the end, okay? And there's tiny little bit of spill on the left. So this is what we would call a right hydrosalpinx. This test is not perfect. So sometimes we will have patients and you as nurses will get the phone call, well, they told me one of my tubes was open, but the other one wasn't. That is true. Sometimes what we see is that the dye stops here, okay? And that is what's called a proximal occlusion. And what I will tell you is that 70% of the time, those are actually open. But it would require me to do another HSG or take the patient to surgery and do chroma pertubation, which is unnecessary. We only give antibiotics to patients when they're doing an HSG when I see a hydro. Other places I have practiced would prophylactically give them like 2 or 3 days before, but it's really hard to like get them to get the prescription, make sure that they checked it, and the risk of infection is low if done appropriately. But what I will tell you is if I have this big hydrosalpinx and I put dye in it, that's a nidus for infection. So as soon as I see that, they get a script for doxycycline for a week. That's what happens, okay? We do a lot of hycosize, so that's, I rarely in my clinic call it that because my nurse would be like, what's that? But what it is essentially when we do sonohistograms, what we're looking for is there's a scintillation process. If you do air fluid waves, if you kind of, instead of you just do water, you can kind of pull the syringe back and do air and fluid. And if you see scintillations, then you can kind of definitively say, yep, it looks like both tubes are open. And the sensitivity and specificity in hands that have done it forever, like me, like it's comparable to HSG. This is an old test. I'm not even going to go into it. I mean, it's in there for completeness sake, but nobody orders that anymore. But the only way to sort of definitively say like your tubes are open is by doing laparoscopy. And so, you know, Kathy's in there every day. She sees this. This is chroma pertubation. So this is essentially using methylene blue dye, and we push some dye and show that it fills and spills. This is what endometriosis looks like. So this is like a powder burn lesion on the fallopian tube, and see how it's completely densely adherent to the uterus. That tube is closed. So how do we treat tubal disease? What I will tell you is that in my fellowship, it was like, oh, we can fix tubal disease by like neosalpingostomies, where we basically make a hole in the fimbria, where we create a hole outside of the tube. It doesn't work. It doesn't work unless you're doing that twice a week, okay? So if somebody is really, the only way to truly treat tubal factor disease, if it's bilateral, is IVF, okay? If I really have somebody who is like desperate, cannot, you know, ethically consider in vitro fertilization or just something, then I will send them to a place, like I will send them to the Cleveland Clinic, where they're doing neosalpingostomies and they're doing fimbrioplasties all the time. Because the bottom line is you have to be exquisitely skilled at doing this in order to have the success rates, okay? And it depends on how bad the tube is injured, and the majority of the tubes that I see are injured so much that there's no way that I could surgically repair it. So I often will tell patients and break their hearts and say that there is no way that I can surgically repair this tube. You need to do IVF. All right, so uterus. We see a lot of fibroids. They're really common. We see a lot of uterine adhesions from they had a delivery and then they hemorrhaged and they went back for a D&C and they scraped the tissue, and that is like the biggest risk factor that you can possibly get developing intrauterine adhesions. We also see endometrial polyps and we see chronic endometritis. We see congenital malformations. So these are called Müllerian anomalies, and the most common one that we see is something called a septum. So your uterus is formed by two tubes that sort of kind of migrate downwards. They fuse in the midline and then they resorb to form the uterus. But what happens is that sometimes those tubes don't fuse, and then sometimes they don't resorb. So the lack of fusion causes like a didelphic, so they've got two uteri, okay? The lack of resorption generally causes a septum. And septum is the one that is generally the most associated with infertility. Didelphic uterus, bicornuate uterus, arcuate uterus, those are all should not actually affect fertility. Unicornuate uterus is its own beast, and those people should just come up to us but the bottom line is they are associated with a little bit of infertility. But what we do for septums is we actually resect them. If this part here, this partial septum, it is avascular, meaning it has very minimal blood supply. And so people who have pregnancies that implant on that septum generally miscarry. And the reason why they miscarry is that there's no way for blood flow to sort of get established for the pregnancy. So if you resect it, then that sort of restores blood flow and opens the cavity, and patients, like their pregnancy success rate goes back to what it would be if they didn't have a septum. And that's true whether you have a simple or a partial or a complete septum. So fibroids, 20 to 40% of all reproductive age women. There is a lot of literature out there on fibroids, and what I will tell you is that it's super controversial. Most of the literature would say that fibroids, if they're large, can contribute to subfertility, but generally don't cause infertility unless there's a tubal problem, okay? And so about 10 years ago, everybody was just like, you saw a fibroid, you were taking it out, okay? And with new data and kind of everything, what we were finding is that we were doing a lot of uterine surgery and we weren't necessarily improving fertility outcomes. And so we sort of don't operate on fibroids unless they're intrauterine, meaning on the inside of the uterus, or if they're intramural, meaning in the muscle, and they're big. And what I mean by big, like they need to be greater than 5 centimeters. So these 2 centimeter, 3 centimeter little distal fibroids, that's probably not causing fertility. Unless it's causing you to have, because you've had inflammatory change from the fibroids or associated endometriosis and that's causing tubal blockage, your fibroid probably isn't causing your fertility. Particularly, the most common site of fibroids is posteriorly on the uterus, and even if it's gigantic but it's way out of the way, it's probably not causing fertility. Okay. So like I was saying, the best studies on kind of fertility and fibroids are IVF cycles with and without fibroids. And like I said, submucosal fibroids decrease pregnancy and delivery rate, and there's a 3 times increased risk of pregnancy. So that's where you're going to see us saying, you know, those need to come out. You have decreased IVF success, 70% for submucosal fibroids. And 30% for intramural fibroids, again, if they're very large, okay? But if they're subserosal, just under the capsule, doesn't change fertility at all. So certainly we remove all submucosal fibroids, and then intramural fibroids, I will remove them if I really feel like it's impinging on the cavity or if it's causing a problem or if they're having pain, if they're greater than 5 centimeters. But if they're 2 to 3, I just kind of leave them. Okay. So intrauterine adhesion, so especially susceptible 2 to 4 weeks postpartum. So if you are in labor and delivery and you have this patient that she hemorrhages and you're rushing her back and they're scraping the uterus, just be thinking, you know, this is the setup for infertility issues from adhesions, okay? And what I would say in those patients is that I would probably recommend that like 8 to 10 weeks after delivery, once they've like recouped, once they're like even, you know, once they're back from maternity leave, just do an HSG, do a sono, do something. Just make sure that you've said, okay, your cavity looks okay. Because nothing is more frustrating for a patient than, you know, they had to do the D&C to save my life, and now, you know, I'm 3 years later and I haven't gotten pregnant again, and it's just better to kind of look in advance. Same with ectopics. If somebody has an ectopic pregnancy and let's say they remove the tube or they treat it with methotrexate, just do an HSG like 6 to 8 weeks afterwards and be like, so that you can give them the appropriate information on like, okay, yeah, these tubes look fine. I know you had an ectopic pregnancy. We treated with methotrexate. Great, things look fine. But it gives them, again, it empowers the patient to give them the information that they need for their future fertility. Polyps. So I had a really hard one today, but we remove a lot of them all the time. And the studies on why we do them are actually interesting. Everybody thinks it's on IVF studies, and it's not. It's actually on IUI studies, so intrauterine insemination studies. And what we found was that these polyps are space occupying, and they also secrete sort of like inflammatory mediators, which prevent implantation. And so we take them out because pregnancy rates in the fertile and infertile population are higher. Okay. How do I diagnose a polyp? Usually I do it by saline infusion sonogram. So this is interesting, and this is why it's important to order a sono. This is the same uterus. So see how you'd be like, it doesn't, I don't know, that might be something in there. And then you put water in there and you're like, oh, that's a gigantic polyp. So the bottom line is, again, if you don't do the test, you're never going to find the answer. So if you feel like, and if you're concerned, or if you see anything that's suspicious, do a sono or send them upstairs. Can cervical factors cause infertility? And the answer is yes, but rarely. You have to really damage a cervix in order to cause significant fertility issues. But what things do we do in women's health that damage the cervix? Well, we cryo it, right? We biopsy it. We burn it with like a leap. So all of those things decrease the normal mucus production of the cervix. And the cervix job, in addition to dilating and delivering a baby, is to make mucus. And the reason why it makes mucus is sperm utilize that mucus to travel through the uterus travel through the cervix into the uterus through the tubes to get to the egg. And if there's no mucus production, the sperm can't get there. So certainly, I think if they've had any cervical procedures, that is going to be somebody that you're going to be like, you should really do insemination. This isn't somebody who you can just give letrozole or clomid to. Again, this is somebody that probably requires some, more advanced treatment. The worst case I've had was a gal who had a cone for adenocarcinoma in situ of the cervix, and she completely scarred shut. And Maud and I took her to the OR, and we did it was like a 2-hour surgery, which for us is a lot. And to try to kind of create a passage and recreate it. And she's pregnant now, and it's like the happiest thing in the world, but it was really tough. So just to kind of think about, when your doctors are doing a leap or when they're doing things like that, I mean, this does happen. It is something that we see. Okay, so other things to sort of think about, I am not a primary care doctor, right? I am a specialist and patients refer to me. But that being said, that doesn't negate my responsibility for taking care of patients, right? And so things that we do is we make sure that the patient's up to date on their pap smear, okay? If the patient is not up to date on their pap smear, I'm going to do it because the last thing that we want to do is kind of miss a cervical cancer. I cannot tell you the number of patients that we see come in from elsewhere that they've been seeing their doctor for years and getting clomid, getting letrozole, doing evaluation for abnormal uterine bleeding, but they haven't had a quote-unquote annual, and they're not doing their paps. And so then, we've picked up cancer, and it's a shame because, again, infertility is this all-encompassing diagnosis, and patients live, breathe, and die for years with this diagnosis, and they fail to get the appropriate treatment that they need because all they can think about is having a baby. So, suffice to say that, if you're evaluating someone for infertility, make sure they're up to date on their PAPs. Things that are recommended that we should test for are rubella status. Are you rubella immune? Are you varicella immune? And things that we offer everyone at our clinic are genetic testing. So AGCOG came out with a recommendation that anyone presenting for a preconception visit be offered genetic testing to see if they carry bad genes. So in the Caucasian population, the genes that we're the most worried about passing on to our offspring are cystic fibrosis, spinal muscular atrophy, and 1 out of 25 Caucasians are carriers for those. So as a carrier, it doesn't really mean anything. But if a carrier marries another carrier, you have a 25% chance of having a child affected by that disorder. And the kicker is that with fertility treatment with in vitro fertilization, you can actually biopsy embryos to ensure that those embryos are not affected by that particular diagnosis before transplanting them back to a uterus. So certainly it behooves you to kind of offer that. Weight loss. So there was a recent New York Times article. Has anybody seen this? I'm sure, I know, like in our field we saw it. There's a, that too fat to get pregnant, which I just cringe, like, ugh. And it went into kind of talking about how there's a lot of fertility clinics across the United States that do not do fertility treatment on women with certain BMIs. I will tell you at Mayo, our BMI cutoff was 40. We did not do any fertility treatment over a BMI of 40. And it didn't always sit well with me, but it also, I recognize that we all know, and we've all been, I was an OBGYN before I was an REI, and I recognize that those pregnancies in obese women carry an inherent risk. Preterm delivery, preterm labor, gestational hypertension, preeclampsia, and they can have bad things that happen. But what I would ask you to think about when you're dealing with these patients is, let's say they're 39 and their BMI is 42 and they've never had a baby and they just married somebody 6 months ago. Think about how they're processing that. They just met the love of their life, they want a family, but they're old and they don't have time. And so we as REIs have to sort of balance kind of what they want, but also recognizing them that they need to have the appropriate counseling to make the best decision for them. So it's not as easy as like, you should do this, you shouldn't do this. It's certainly a patient population. I think if money grew on trees with everybody with morbid obesity, we would say, okay, we're gonna stimulate you, we're gonna get some embryos, and then you're gonna lose the weight, and we're gonna transplant them once you've lost the weight and once you've recovered for bariatric surgery. But we live in a non-mandated state. Patients can't afford IVF. And so we sort of have to say, these are your risks. I will tell you how I handle it is that anyone with a BMI greater than 45, I make them see a dietitian and I make them do 3 to 6 months of attempted weight loss. But I have a really hard time when they've done that and they've worked really hard, them coming back and me being like, I'm not gonna treat you. Because it's just hard because they may not have time. If they're 28, clearly, like, you need to lose the weight, come back to me once your BMI is under 40. But once they're old and if they really put in the time, there's studies also that show that the weight loss, that the small weight loss that men and women can get over, it doesn't actually increase fertility rates in the short term. It does improve pregnancy rates as far as pregnancy complication, but we see morbidly obese patients getting pregnant all the time. But, again, I have a captive audience. I recognize that, but I also feel like we have to sort of recognize that, life from point A to point B isn't always a straight line and things happen and you have to meet patients where they are. And so that's sort of my soapbox on that. We talked about smoking cessation. Don't do cocaine. Occupational environmental exposure, my nurses will laugh. How many times have you gotten a call from somebody that's like, I'm sitting in my office and they're painting and there's fumes, and you're like, it's fine. So the bottom line is, the one caveat I will give is if the male is a welder, and he's around kind of heat all the time, that is kind of a buzzword on boards and questions that certainly that can contribute to male factor infertility. But as far as female factors go, there's minimal occupational environmental exposure. Last thing, so unexplained infertility. Again, diagnosis of exclusion. You can't make the diagnosis of something unless you've done the workup. So you have to have sperm and you have to have tubal evaluation. What I will tell you is, let's say that your doctors have done the labs that I've talked about, they've done a semen analysis and they've done a tubal factor evaluation, and they're giving out well, just try some Clomid. Okay, the chances of that working are 2 to 4%, period. That's it. That's all they get, 2 to 4%. You only get the benefit with unexplained infertility when adding it with IUI. Now, again, money is a thing and it's real, but it needs to, the patients need to understand that Clomid is not a be-all answer, and particularly in unexplained infertility, that is not what I would do. There are studies that show that gonadotropins alone are no better than Clomid plus IUI. I will tell you that that is statistically what I see, but anecdotally in our clinic, that is not what I see. So the bottom line is most of these patients, if they've done any Clomid or letrozole, they will come to me. I will do gonadotropins and IUI. Or again, if money grew on trees, IVF is the answer. So again, this is kind of like the statistics, but if money grew on trees, IVF is the answer. And that is it. Let me stop there. Like, let's talk. Like, I talked a lot, and I'm here to answer questions and whatever else I can answer. Any burning ideas, questions, anything? Nothing? Crickets? All right. Yeah.
You tell the patients, and I might have missed this, but you said call with their first day of the menstrual cycle, and then they come in, what, 2 to 3 days later?
Yeah, so like cycle day 3 or 4, fine. Yep. And then you just get them. And usually, you know, like if you're getting a prolactin level, and something that I didn't touch at, but like here, prolactin is notoriously, and our assay is extremely sensitive. Like other places I've practiced, holy crap, like, I mean, it picks up everything. But I will tell you that, you know, it behooves you to do prolactin during the follicular phase, the early part of the menstrual cycle, and fasting, because you can see high levels of prolactin if they've eaten food that day, if they took a shower, if they laid on their breast that morning. I mean, that is not a perfect test. So if you're going to do that, do it cycle day 3 with the other labs. Yeah.
Money's a big issue with infertility.
Yeah.
So when does insurance cover? When do they not cover?
Oh, so it's getting better. So
Preliminary stuff that you do,
usually it's covered.
mostly cover all of that?
Yeah. So I think 96% of all insurance companies will pay for the preliminary workup. That's why I tell everybody, do the workup. The issue that comes into hand, which is very frustrating, is if you don't do the workup, let's say you're like, I'm just going to try some Clomid and we'll see if it happens. If you give them Clomid, they deem that you have already made the diagnosis of infertility and then retroactively will not cover the workup. So you got to do the workup. You got to do it. The patients will argue, well, you know, my husband's had kids. I don't care. Like, if you don't do a semen analysis now, you're going to pay for it in 6 months when you're not pregnant. You know, I mean, because it's covered. So if you're going to give somebody medicine, again, if somebody comes to you, they're having palpitations, you don't just throw them on a beta blocker. You know, do the workup. So the workup is generally covered. We are seeing a lot more insurance coverage over probably the last 5 years. So I used to work for Dr. Doherty, in college. So, I mean, I'm old now. But there was no fertility coverage back then, none. And I would say, I don't know, Jewel, how do you think that's changed over the period of time?
I think it's gotten better. I mean, you definitely see more. It just depends on where you work. Some people at the med center, though, now depends on the
University of Nebraska, the actual University of Nebraska pays for IVF. I would really hope that, you know, usually when the University of Nebraska or when, like, you know, the state comes forward and offers, I would hope that Methodist would follow in suit, but they haven't yet. I will say that there's companies now that are like third sourcing their infertility coverage. It's called Progeny. It's big. So and those are all of like the tech companies. So like LinkedIn, Facebook, Google, everything, PayPal, and they cover
BGS testing and
they cover everything.
now there is a limit, like
They can do 2 IVF cycles. And in those patients, I mean, again, it's important to know whether or not they have that progeny benefit, because if they do like Clomid IUI cycles downstairs, they're losing their benefit.
sounds like a quarter of
Yeah.
There's a way they figured out with their and they have like an advocate with them that they work with through Progeny and then they do it to our clinic.
So like those patients, like we don't even mess around with doing IUI on them because, you know, it's a lower success rate. And so we just usually go straight to IVF with those patients because they have coverage. And I think that's that's sort of like the trend. Again, we see all these these multiples when we're doing gonadotropins and IUI or Clomid and IUI or letrozole and IUI. And with IVF, you know, the higher sister multiples is when you transfer more than one, but if you're transferring one embryo, the chance of multiples is 3%. So, you know, I think in the future, I think that will change dramatically. I mean, I think more companies are going to provide coverage, and there are 17 states now that are mandated. I've never worked in one, but it changes like the atmosphere. It changes like, I mean, my colleagues that work in New Jersey and New York and California and Chicago and what are some other ones? I mean, like their practice is completely different than ours, and it's because like basically they just do IVF. I mean, because everything's covered. So. Generally speaking, you can quote if you're going to do IVF, the cost, I generally quote people if you're not going to do genetic testing, it's around $15,000. If you're going to do genetic testing, then that's when you're getting closer to $20,000. Gonadotropins and IUI, generally $3,000 to $5,000 per cycle. And again, success rate of IVF is around 65%. Success rate of gonadotropins IUI is around 25%.
So backwards, patients, you know, they've been over there and had IVF and they come in with miscarriage.
Oh, it's just awful. It is. And the only thing I can tell those patients is that, you know, I think miscarriage in general is very like emotionally charged. And it's important to remember that really like 20% of pregnancies miscarry whether you do IVF or not. And so, you know, certainly it's so hard, but, you know, there is benefit to knowing that you can get pregnant, and the statistics on miscarriage would say that until you've hit 5 miscarriages, your chance of live birth is still good. But everyone is hard, like especially the recurrent pregnancy loss, you know. I mean, I can tell them, I can say, I know it's hard and you've had 3 losses, but the statistics are still good. We just got to keep trying, but it is emotional toll on those patients. So.
There's additional workup that we do.
For recurrent pregnancy loss, yeah, which I did not include as part of the talk, but happy to provide it if you guys want next time. Next time. So. Anything else? Yeah.